Hello, everyone. My name is Adu Gyamfi, and today I'm here to present my DNP project titled Implementation of the Ask Suicide Screening Questions Tool to Improve Suicide Risk Detection in a Community Health Clinic. My faculty chair is Dr. Davis Graham, and my second faculty reader is Dr. Marie Snell, both of Maryville University. And my community reader is Jane Njangi, registered nurse in the community. Just a little background. Suicide is the leading cause of death in the United States, with over 49,000 deaths annually, according to the CDC. And this was in 2024. Vulnerable populations are at increased risk, especially immigrants, low-income individuals who obviously face a higher risk and are also with reduced access to care. Many individuals who die by suicide have had recent contact with a healthcare provider, so there is a missed opportunity for intervention when they meet a provider. The clinic that the setting for my project lacked a standardized suicide risk screening process, leading to a critical patient safety gap. So, going back to the settings again, so it's a community-based free outpatient clinic based in central Massachusetts. It serves uninsured, underinsured immigrants and low-income populations. It operates on a limited weekly walk-in basis every Thursday from 6 p.m. to 8 p.m. It is staffed by a volunteer multidisciplinary team that includes physicians, nurse practitioners, registered nurses, and some students. Actually, the students could be nursing students, medical students. Many patients the patients who come in usually lack a primary care provider. They do get fragmented care from different places, and the barriers to them getting care usually it's language, cost of services, and mental health stigma when it comes to talking about suicide. The clinic didn't have any standardized suicide risk screening process, so that means that there's a safety gap over there. This is a picture of the suicide screening tool. And the aim of the project is to implement the ASQ suicide screening tool in a community health clinic. Review of literature. Basically, many of the individuals who die by suicide have had a recent contact with healthcare providers, therefore leading to a mixed opportunity for detection. Universal screening improves identification of at-risk patients in medical settings. The ASQ tool is a brief 4 to 5 questions. It's validated across populations. It's feasible for outpatient and primary care use, according to Horowitz et al. 2020. Obviously, like I said, it's a standardized screening tool, improved consistency and reliability. It also has a reduced reliance on subjective clinical judgment. Screening is most effective when paired with brief safety assessment and then appropriate interventions and referrals. Barriers to implementation include time constraints, since this is something that is being added to what the providers are already doing. Provider discomfort in asking questions, intimate or discreet questions with the patient who they just met. Then also patient stigma and reluctance to disclose any information to a stranger. And then the evidence supports integrating screening into the routine workflow to improve patient safety. theoretical framework that was used in the project was guided by Lewin's three-stage change theory. The first part was the unfreezing part, which is identifying the gap in suicide screening, educating staff on the need for change. And then the change part is the implementation of the ASQ tool in the clinical workflow with provider training. And the refreeze part, establishing screening as a standardized routine practice. And the framework was supported by the structured implementation process, staff engagement and acceptance, sustainable practice change. This ensured the project moved from a program recognition, implementation, and long-term integration. The method used for the project was basically a quasi-experimental pre- and post-intervention. In the setting, obviously, was a free outpatient clinic in central Massachusetts. The sample size, adults greater than or equal to 18 years old, and the total was 178 patients. The sample in a little bit more detail, total sample size, like I said, 178. During the pre-intervention, 78 patient chats were screened. And during the post-intervention, 100 patient chats were screened. The inclusion criteria were adults 18 years old who were seen by a provider during the clinic visit and also consented to have their data used in research. And the patient population was predominantly uninsured or underinsured immigrants and racial ethnic minorities, low socioeconomic status. Clinic characteristics, many patients lacked a primary care provider and then presented with non-emergent medical needs. And just to go over a little bit more with the sample, basically patients coming through the clinic, they fill out a chart to be seen. As part of filling out the chart on the consent sheet, it gives they are consenting to have their data or chart be used for a project. In addition to that, I provided them with a project intervention sheet. Project information sheet. And this was given to patients after the intervention had been implemented. So patient will do their consent. They will then be given the patient information sheet. They will review it, and if for whatever reason they decline to have their information used in the project, we'll discuss that with them, and then obviously they will, if their information will not be used. Fortunately, no patient declined to have their information be used as part of the project. After reviewing the project's information sheet. Data analysis. So the data was collected after clearance had been received from Maryville IRB committee, and what had happened was I then went in, collected data from 9 weeks before the intervention and 9 weeks after the intervention. I was able to get a pre-intervention information because the clinic, after the introduction or discussions of what the project was going to be, clinic leadership decided to implement the ASQ tool right away, even without the education. And so that was the pre-intervention data. Data analysis. Statistical test was used, and I used a 2-proportion Z test. And the purpose of that was to compare proportion of positive suicide risk screens and this was done between the pre and post-intervention groups. This test was chosen because the outcome variable was categorical, meaning I had a yes or no, and it was easier to compare two independent groups. And this is appropriate for analyzing differences in proportions. The software used was IBM SPSS. To basically G-power analysis was completed. The significance level alpha equal to 0.05. Regarding the results, pre-intervention suicide risk screening, out of the 90s, out of the 78 patients, basically there were 9 out of the 78 patients that screened positive. And then with the post-intervention, 0 patients screened positive. The chats that were reviewed were 100 chats for the post-intervention, but 0 positives were observed. So the statistical finding, disease score was equal to minus 3.49, and the p-score was 0.9998, meaning there was no statistical difference noted, so couldn't be rejected null. Power 1 minus beta was equal to 0.046, low, very, very low statistical power. Limitations of the project. Small sample size can be considered, limited ability to detect meaningful differences. And then also the short data collection period of 18 weeks might have been the reason why no positives were captured. The other issue could also be the single site setting, limited generalizability to other populations. No positive screens, therefore no post-intervention. Limited evaluation of provider response was also an issue. Low statistical power, mentioned that earlier, 0.046. And then patient-related factors, could be patients were reluctant to disclose suicidal thoughts. There's also the issue of cultural stigma around mental health. There's also language barrier, but interpreters were used throughout the project. And that's just something that the clinic does. Provider-related factors could be time constraints during visits. Providers are already asking other things, and adding this might have been an issue, but just something to think about. And then, both provide a variable discomfort with suicide screening with the patient who they haven't established appropriate care. Discussion-wise, screening did not increase detection statistically, but the standard suicide screening was successfully implemented. Provider awareness improved. Also, documentation became consistent instead of just asking patients and documenting it in the patient's chat, but we were able to use the suicide screening as a formal documentation tool. Then screening was also normalized as part of the mental health discussions for all patients. Implications for nursing practice. Nurses play a key role in early suicide risk identification. So having this tool be available to them can really go a long way to help improve safety at the clinic. Standardized screening also indeed does improve patient safety and quality of care. The other thing too is enhanced team-based care and communication. So everybody knows that the patient has been screened and this is the results, and it's documented in the chat. And it also supports equity by consistently screening all patients, so patients who are not falling through the cracks. It's also reduced stigma through routine mental health assessment. So the more this is discussed with patients, the easier it is for them to also bring up any issues regarding mental health. And then implementations for future research. So larger sample sizes would be a good idea within a longer study period. So instead of having 178, which is pretty normal, I was told, for a DNP project, but a larger size sample size might be appropriate in this situation. Multi-site implementation studies, so other free clinics can also implement this tool and see how what comes out of it. Integration with EHR systems. So this was done on paper. So in the future, having when EMLs are in use, having this already pre-populated in a tab in just a few clicks here and there will also make it easier to complete the assessment. And then another thing too will be to discuss, or explore culturally tailored interventions. How do you discuss suicide screening with somebody who is culturally naive about talking about mental health with a stranger? And then evaluate long-term outcomes, so referrals, hospitalizations, suicide prevention. Obviously, we didn't have any positive screens post-intervention, but that's something to do a follow-up on if you were to have any. Then in conclusion, project impact. So a standardized screening tool was implemented. Providers became more aware of mental health screening, suicide screening. Documentation was also improved. So the clinic now has documentation that it's actually asking patients about their mental health or risk for suicide. Then for future directions, basically expand to more clinics, increase the sample size, and then integrate this into the electronic health record when it becomes available. For my personal growth while working on this project, I did learn a lot of trying to integrate all of these providers within a short period of time, reviewing what needed to be done, which it turned out to be all right. So that was a good job on my part. Evidence-based practice, using literature, reviewing the literature, writing multiple chapters to figure out what needed to be done. And then bottom line was this was a great way to advocate for mental health in the clinic, in the community. So basically, it was great advocating for suicide prevention and mental health equity. Yeah, some references that I used. Thank you very much. If you have any questions, please contact me. Thank you.